I'm a GP in Kirklees with special interest in diabetes and obesity. And also I'm a foundation trainer, a GP trainer, and a training program director for South Sheffield and Barnsley and Heart of Yorkshire Scheme. Today's presentation is on diabesity. My internet at times can give some trouble, so I may have to switch my video off, but I'll let you know if it starts freezing. Any questions, either raise your hands or put in the chat box, and I'm happy to answer them. For today, I'll be dealing with epidemiology, public health perspective, diabesity, which is considered to be the pandemic of 21st century, diabesity, and touching a bit on the COVID-19 pandemic and the capacity load model, and of course, touching on the treatment of diabesity. Before we start, what does diabesity mean? You can put your answers in the chat box. Ash, if you can keep an eye on the chat box. For some reason, I'm not able to see it.
No problems. I'll keep a tab on that.
What is diabesity? Anyone? Just put your answers in the chat box. Jessica, that's fine. Yeah, I can see
Excellent.
now.
Excellent.
Interplay between diabetes and obesity. Perfect. Yes. Okay. So, so the term diabesity, as Jessica mentioned, is a term which was coined by Dr. Ethan Allen Sims, and it is a term which encompasses the two. So there is an intricate relationship between obesity and type 2 diabetes. This is now very well recognized as evidence from the term. So diabesity, it refers to a form of diabetes which typically develops later in the life and is associated with being obese, or obesity, which is associated with diabetes, which is a state of being overweight or obese, of having type 2 diabetes or one of the conditions that precedes it. Meena Murthy in the Home News Tribune in New Jersey, she mentions that hectic work schedules, stress, cheap and easy fast food, sedentary lifestyle, glued to television sets are some of the reasons why people fall into the trap of diabesity. Just a graphic representation of diabetes, why we say it is a global picture. So if you can see in 2017, and these numbers are in millions. In 2017, the top one is Africa. The cases were 15.9 million, and it is expected that by 2045, it may go up to 40.7 million for Africa, and the total burden of diabetes from 400 and nearly 425 million to around 630 million. We are not far away, so Europe is next. So in 2017, it was 58, and it is thought that we may go up to 66.7. So it's time we realize that diabetes is a global problem. So, and it is both taken together, like diabesity is the most concerning medical issue on the planet, to be honest. And the combination stems from the insulin resistance gene, which affect about 30% of Caucasians, 50% of Asians, and 100% of people with darker skin. So If a people with insulin resistant gene is exposed to the modern lifestyle, where there's excessive food, sedentary lifestyle, then all manifestations of obesity and type 2 diabetes may occur. This is a chart from National Institute of Health, and it tells you a summary of all the factors linking to obesity and type 2 diabetes. And you can tell that there is a complex interplay of various factors leading to diabetes or obesity. For example, lipid and fat, because reduced adiponectin in the blood, leading to increased adipocytokines, decreased ATP, affecting the central nervous system, which can then affect food, behavior, and environment, leading to increased free fatty acids, insulin resistance, too much insulin. So it's a very complex mechanism, but there is a massive interplay of all these factors linking obesity and type 2 diabetes. Another rather complicated one, but this is also from National Institute of Health, which tells you about adipocytes and obesity, and this is called the adipokine hypothesis. So it's a very, very complex pathophysiology and shows how both these are interlinked to each other. So COVID-19 pandemic, which we all have been a part of, has highlighted and brought many things to the forefront. It had a very strong impact on the population who had pre-existing chronic diseases. The collision between COVID-19 and diabetes pandemic highlighted that obese diabetic patients had the worst prognosis due to impairment of the immune responses and the most difficult to manage in hospital setting. There was limitation imposed on accessibility to non-urgent care during the lockdown period, which then led to use of technology and risk stratification to establish a priority to access treatment for a new phase, more efficient treatment for diabetes. Keeping with the COVID-19 and diabetes is, as I said, that diabetes was considered the pandemic of the third millennium unless COVID-19 outbreak happened. There has been significant global rise in obesity, and that explains the epidemic rise in type 2 diabetes over the last few decades. So the term is, and diabetes has been coined in an attempt to consider obesity and diabetes as a single disease and not as separate entities, particularly following the pandemic. And the diabetes epidemic would have been the biggest epidemic in human history until WHO declared COVID-19 as pandemic in February 2020. So if you're diabetic and if you got COVID infection, you either had ketoacidosis, hyperglycemia, there was impaired glucose secretion, impaired glucose disposal, and it affected multiple organs, for example, causing acute kidney injury to hepatocyte injury, respiratory distress, stunned heart, also causing acute beta cell injury, immobilization, muscle wasting, viral load causing acute phase reactant cytokines, stress response. And we've seen that most of you would have been involved actively in looking after such patients and may continue to do so because COVID is still pretty much there. We are having a lot of admissions. So that's when, because of the pandemic, the importance of dealing with obesity and diabetes came to the forefront even more. As I said, diabetes epidemic is likely to be the biggest epidemic in human history, to be honest. it has been seriously underrated as a public health issue. And it's time that the world stops ignoring the rise of the diabetes mellitus cases. And also, these estimates have significant limitations from a public health perspective. And we need more reliable estimates of future burden of type 2 diabetes urgently, to be honest. So type 2 diabetes has been is called as modern preventable pandemic, mainly because there are several human factors and we can prevent it. There was this literature and a policy review which was performed to analyze the data about COVID-19 and type 2 diabetes to establish their multifactorial health, social, and economic impacts. And it came out that with the global prevalence of type 2 diabetes trebling in the last 2 decades, it has become a modern preventable pandemic due to modifiable human factors. With proper education and access to resources, it is possible to mitigate the type 2 diabetes, what we say the modern preventable pandemic, only through focused government policies. Without government intervention, it will continue to grow at an unsustainable pace. And the scale of the type 2 diabetes pandemic warrants a robust response in the health policy. So what happens when 2 pandemics clash? So COVID-19 and diabetes. So these are the various impacts that we see. So impact on glucose control, on the prognosis of COVID-19 infection, impact of medication on prognosis of COVID-19, concerns about the efficacy of vaccines in patients with diabetes. And in terms of the impact of the COVID-19 pandemic on the whole healthcare system, and we are still seeing the impact of it, and impact on lifestyle. So that led to, because things were remote, non-face-to-face, it led to the development and implementation of various technologies for caring patients with diabetes. And also there was a massive concern regarding new onset diabetes in patients who had been non-diabetic after the pandemic. A rather busy slide, but so diabesity epidemic in the light of evolution, there is this model which is called the capacity load model. So it's basically the metabolic capacity which promotes the glucose homeostasis, and metabolic load which challenges the glucose homeostasis. And population variability in type 2 diabetes prevalence is consistent with this model, indicating the effect of obesity varies with ethnicity. Those who are exposed to adverse environments may express or develop several metabolic traits that are individually beneficial for reproductive fitness, but which accumulatively increase diabetic risk as well. Public health interventions can promote metabolic capacity, but that means that efforts to curb the metabolic load in terms of obesity and healthy lifestyle must remain at the forefront. So this capacity load model, this is just a graphic representation. It takes into account maternal factors, which includes undernutrition, short stature, obesity, infection, psychosocial stresses, and lifestyle factors in terms of lipogenic diet, sedentary behavior, smoking, obesity, infection, psychosocial stresses. There has to be a good balance between capacity and load. Any imbalance can affect the blood sugars. So metabolic capacity against metabolic load and the risk of diabetes. So this is just a graphic representation of the previous slide. Okay, so we'll take a pause there, and if you could put in the chat box some of the anti-diabetic medication names which cause weight loss. Exenatide, SGLT2 inhibitors, yes. Semaglutide, yep. Few more. And name some anti-diabetic medication which cause weight gain. Yes, sulfonylurea, Sophie, but yeah. Anything else? We use it all the time in secondary care when patients are admitted, diabetic patients admitted and well. Yes, sulfonylureas, John, that's right. Insulin, yes, Millie, yeah. Okay, yeah, we've had a few responses. Okay. So this is just a slide from 2014, which was linking the obesity and the diabetes prevalence. And so the red circles are South Asian populations. The blue triangles are Middle Eastern, North African population. The white circle is all other population. And the graph A represents diabetes and obesity prevalence in women. B represents in men. C represents adult female height, and D represents adult female birth weight. There is a real correlation, as you can see. Now, going on to diabesity, as we discussed a few medication that we put in the chat box, there are major breakthroughs for this condition. So SGLT2s, you just put, some of you put in the chat box, GLP-1 RAs as well. Yeah, semaglutide was there, exenatide. There was a study which was conducted for less than 2,000 patients who were obese, but not diabetic. And this study was published in a New England Journal of Medicine. So the GLP-1 agonist semaglutide, Ozempic, that's the name it's marketed as. This study showed that there was the weekly subcut injection in actively treated group compared with placebo induced an average 15 kilogram weight loss after 68 weeks of therapy, which was quite significant, to be honest. So some of these anti-diabetic medication which have beneficial benefit on the weight, so metformin, weight loss, GLP-1 analogs, exenatide, liraglutide, they do cause weight loss. DPP-4 inhibitors are weight neutral. Amylin analogs, they do cause weight loss as well. SGLT2s, canagliflozin, DEPA, AMPA, they cause significant weight loss as well. And studies are going on to involve SGLT2s in managing obesity. So we may have the data pretty soon. This is another representation, a graphic representation, which shows, so metformin does cause weight loss, not significant. SGLT2s, yes. GLP-RAs, definitely. DPP4 inhibitors are weight neutral. Thiazolidine, sulfonylureas, insulin, they all cause weight gain. And you can see the insulin is the top of the list, to be honest. And at the same time, weight loss, GLP-1RAs cause significant weight loss. Obviously, we're waiting for more data for SGLT2s as well. So this is just a graphical representation from of GLP-1RA in diabesity as to how it works. So moving on from anti-diabetic medications causing weight loss or weight gain, can you name some anti-obesity medications? We've named some there. One medication which is used in general practice for all those of you who've done general practice placement, if you've used it, the only medication, orlistat, yes, as a metformin, anti-obesity, it's yes, for metformin is mainly for those with diabetes, not for obesity on its own. Yeah. Anyone else? Have any one of you prescribed an anti-obesity medication to your patients? Has anyone prescribed orlistat in the GP placement? Okay. No worries, I'll come to that. Anyone? Not, we just go back, yeah. So this is a summary slide of all the anti-obesity medications. So there was this significant change in the guidelines in October 2022, where the American Society of Metabolic and Bariatric Surgery and International Federation for the Surgery of Obesity brought the BMI down for bariatric surgery. So they recommend BMI surgery for adults with a BMI over 35, regardless of any obesity associated condition, and with a BMI of 30 to 34.9, who have associated metabolic disease. Some of these medications, liraglutide, Saxenda, that's how it's marketed in the UK, tirzepatide, naltrexone, bupropion, orlistat, phentermine and topiramate, and semaglutide. Semaglutide, or Wegovy, was approved by FDA for obesity in 2021. As I mentioned earlier, orlistat is the only drug in UK that is specifically for treatment of obesity in primary care. Okay, and it works by reducing absorption of food from the fats from the food. Most common side effect is steatorrhea, increased flatulence, increased urgency, and abdominal pain. So you have to warn the patients because it can be very embarrassing for most of the patients. make sure you tell them what side effects they will be expecting. And the guidelines suggest that you prescribe orlistat alongside hypocaloric diet to patients with BMI over 30 or patients with BMI over 28 with associated risk factors as type 2 diabetes or hypertension. And they must show a 5% loss in body weight in 3 months. So what we normally do in primary care, when the patient come in requesting for orlistat and they are eligible for it, we just weigh the patients, calculate their BMI, tell them what are the side effects and how to take it. And at the same time, we calculate because they have to lose 5% of the weight in 3 months. So what you do, you calculate how much they should be losing and tell them and document, look, you got to lose this much in 3 months. Otherwise, I'm afraid I won't be able to do any further scripts. So we do 28-day script or 4-week script, and then they come in to see the nurse or the healthcare assistant or the GP. You weigh them again, do another prescription. 3 months, they should have lost 5%. And if they can't, you have to stop prescribing. So this was, research has shown that orlistat is effective in treatment of obesity when compared with placebo. A 1998 study shows subjects lost 37% of the weight. 37% of the subject lost more than 10% of the body weight compared to placebo, where they only lost 90%. A further study in 2011 compared all of these weight loss, which was quite significant, BMI, waist circumference, total cholesterol, and LDL loss. So there's quite significant data to support orlistat against placebo. And we normally prescribe 120 milligram 3 times a day for, as says, a month, 28-day prescription and 3 prescriptions. If they have lost 5%, they continue to be on it. And this study also, there was this study who found out that the prescription for orlistat has decreased significantly since 2010, where the number exceeded 1 million across England. And in 2020, the number of prescriptions was just 294, around 300,000. Monthly prescription cost for orlistat is around £27 per. Northeast and Yorkshire have the second highest number of prescription per 1,000 population, more than 10 per 1,000, and this coincides with the greater obesity level in our region. So just a mechanism of action of GLP-1 is when you eat your food, small intestine secretes GLP-1. In response to food, it decreases the appetite, slows gastric empty, stimulates the pancreas for insulin secretion. And it was seen that the average percentage loss from baseline to 1 year for liraglutide was 6.2 to 8%. When compared to semaglutide, it was 4.8 to 13.8%, so quite significant weight loss with semaglutide. So liraglutide, which is marketed in the UK in the name of Saxenda, is being licensed for use by NICE. Mainly in the secondary care prescribing. We can't prescribe in primary care, though we use liraglutide, not Saxenda, for my diabetic patients, but that's, I can't prescribe Saxenda. So the King's College, they produced this guideline. Mainly this was kind of updated during pandemic because everything moved to non-face-to-face. The prescription for Saxenda is completed by the physician in obesity or pre-diabetes pharmacotherapy clinics or after bariatric multidisciplinary meeting. The medication used to be posted to the patient by outpatient pharmacy, or the patient came and collected it. And the consultation was either undertaken by bariatric physicians and their respective teams from the obesity or pre-diabetes pharmacotherapy clinics. So the eligibility criteria for Saxenda is there are two criteria: treatment criteria 1, treatment criteria 2, and all adult patients have to meet all bullet points. So the BMI criteria over 35, adjusted for minority ethnic groups, remains the same for both treatment criteria 1 and 2. And then criteria 1, you either have non-diabetic hyperglycemia, which we call pre-diabetes, or a fasting glucose of 5.5 to 6.9, or a 2-hour post oral GTT 7.9 to 11. And you are at high risk of cardiovascular disease as hypertension or dyslipidemia. For criteria 2, you had minimum of one or other medical comorbidities or psychological factors where weight loss by medical management may benefit as assessed by the consultant obesity physician. So these are the criteria for Saxenda. And this is the pathway from King's College for liraglutide initiation. So once as GP, we refer these patients to the tier 3 weight management service. I'll come to it later as how these weight management services work. So they are assessed first, and if they seem to be meeting the inclusion criteria, a prescription is initiated for 2 months, 0.6 milligram increments for 4 weeks, and then the maintenance, so they reach a maintenance dose of 3 milligrams of Saxenda. After 8 weeks, they have a review in the clinic. The patient is assessed. If they are not able to tolerate it, the treatment is stopped and the patient is referred back to the GP. If they are tolerating fine, then another prescription is issued for 4 weeks, and then they are reviewed in the clinic. At this point in time, 12 weeks from the initiation of the therapy, they should have lost 5% of the body weight. So if they've lost 5% of the weight, then they start getting 3 monthly prescription. During pandemic, they had to take a picture of their weighing scale and send it to the consultant, and then they got further scripts for up to 2 years. But if they have not achieved 5% weight loss, the treatment is stopped and they're referred back to the GP. Following 2 years of Saxenda prescription, then a decision is made whether, or before or after, whether the patient is eligible for bariatric surgery. And the eligibility is obviously weight, height, BMI, blood pressure, heart rate, and we do some baseline bloods. And in addition to Saxenda, they are advised to follow 500 kilocalorie over 24-hour deficit diet based on the evaluation of their estimated BMR. So this is the guidance for liraglutide initiation therapy. Then 8th of March 2023, we get this miracle drug, and BBC announces weight loss drug semaglutide approved for NHS use. Wegovy, that's how it's marketed in the UK. This is going to be a game changer. It is a weekly injection, mimics the action of GLP-1, a gut hormone that promotes the feeling of satiety, same mechanism of action. But again, as a GP, I cannot prescribe semaglutide. Though I prescribe semaglutide, Rybelsus, to my diabetic patients, but I can't for my obese patients. But it isn't a miracle. 2/3 of the people will regain their lost weight within 2 years. So we know how it works. So semaglutide, Ozempic, and Rybelsus. Ozempic is once a weekly injectable, and Rybelsus is the daily oral semaglutide. These are licensed for type 2 diabetes, and Wegovy is licensed for obesity. So the key message: cannot be initiated in primary care, but refer people with complex obesity to these weight management services. And NICE has approved maximum of 2 years in specialist weight management service, tier 3 or tier 4. And they should have at least one weight-related comorbidity, BMI of 35, between 30 and 34.9, if they meet the referral criteria. NICE also recommends to lower the BMI threshold by 2.5 for people from South Asia, Chinese, other Asian, Middle Eastern, Black African or Afro-Caribbean family backgrounds. And stop treatment if less than 5% of initial weight has been lost after 6 months of treatment. So you stop after 6 months if they've not achieved the 5% weight loss. The other medications, tirzepatide is marketed as Mounjaro. It is a GIP-1 and GLP-1 RA. In trials, it has been shown that you lose more weight than those on standard diabetes therapy, but these are not licensed in the UK. Phentermine and topiramate, marketed as Symia. Topiramate causes weight loss in several ways, makes you feel full, food tastes less appealing, burning more calories, and not approved for long term, just for a few weeks only. Naltrexone and bupropion. Naltrexone is used for treat alcohol and opioid dependence. Bupropion for stopping smoking, depression, and STDs. This study by Himadri Singh et al. It goes about treatment for diabetes beyond pharmacotherapy. So he says that obesity is a prominent risk for type 2 diabetes. So management requires weight management alongside glycemic parameters. And the study suggests using metformin, SGLT2's GLP-1 receptor as the first line, controlling both hyperglycemia, body weight. And he mentions that sometimes you have to use SUs, thiazolidinediones, insulin in chronic cases as well. They do have some benefits as well. And it discusses the treatment strategy, controlling glycemia and weight management as well. Medical management of diabetes. Do we have realistic targets? So retrospective studies have shown that combination therapy with GLP-1 and SGLT2, when administered along with other anti-diabetic medication, offers the best therapeutic benefit in medical management. Different combinations of other anti-diabetic drugs with minimum weight gain potential were also found useful. There is, because of the lack of sufficient evidence based on prospective RCTs, future research should focus on evolving the appropriate rational drug combination for medical management of diabetes. This is just some of our options, how we can tackle both diabetes and weight. Surgical management alongside the standard ones, there are these, it's evolving every day. Bariatric surgery, endoscopic bariatrics, and metabolic therapies. So these are some of the options available. Skip this slide. Yes, so this is a slide quite like it, which says principle of care or goals of care. So it has to be, we have to look at medication for glycemic management, weight management, cardiovascular risk factors, cardiorenal protection. So it has to be the treatment should be targeted on all aspects. So this is what I was saying very quickly to finish my talk. So we have, these are the weight management tier services. It says CCG, now we have the Integrated Care Board, that's been replaced by ICBs. So tier 1 is the intervention which we do in primary care. So our practice nurses, healthcare assistants, GPs. So just reinforcing healthy eating, physical activities guidelines. And then tier 2 is again GPs, general practice, plus there are some weight management services which we can refer patients to. Sometimes they're based on, patients do get some vouchers for exercise program, gym membership. They get some vouchers for all these diet programs that they go to. Then tier 3 is the one that we were talking about, and this is by the Integrated Care Board, which we refer to in the specialist weight management services in the secondary care. These are led by the consultants or GPs who will have special interest in diabetes and obesity, specialist nurses, dietitians, psychologists, psychiatrists, and physiotherapists. And tier 4 is hospital-based specialist care, is mainly bariatric surgery, which is supported by the MDT team for pre-op assessment, post-op follow-up, and specialist medical services. So these are the tier of weight management services. Unfortunately, where I work, there is no tier 3 service. So it is, so how they have found a way across it. So I have to refer all my patients who qualify for Saxenda or Wegovy. I have to refer them to tier 4 service through individual funding request. Individual funding request is something where there's a panel in the ICB, sits down, looks at your referral and see if they qualify for a special funding on NHS for bariatric surgery. But even though I refer them to tier 4, they don't get a bariatric surgery. They are then moved down to tier 3 and they get Saxenda. So they get Saxenda, now they'll get Wegovy. So how that works in my region, but there are ICBs where tier 3 is up and running. These are some of my references.